from a very challenging field, and since this is the first work done into this direction, congratulations very much. Are there any questions? What do you think will be the next step? How long of airway substitute can be done using this technology?
For this case, it's 5 centimeters long, and I think for the tracheal, for the next step, we will really perform a tracheal replacement, and because the limit of the resection of tracheal is 6 centimeters, but the total lung is 12. So I think if we can succeed in 6 centimeters, we can maybe for the patient you can resect the whole tracheal. So 6 centimeters will be the challenge.
And for how long do you think it is necessary to continue with reseeding and refeeding through these tubes?
We actually continue with the reseeding for 6 weeks because we just afraid of maybe there's some infection of this one. To be frank, I think maybe we can continue with the perfusion until the re-epithelialization finished of the substitute.
Yes, Dr.
I have 2 questions. First of all, congratulations, phenomenal work. One, if these are the patients who have advanced disease, and if patients are willing and appropriate, you would consider pre-op or post-op radiation therapy. More than the chemo, the radiation therapy I would think would be of some consequence. And how comfortable you are if somebody is willing to undergo radiation or appropriate, when can they start if you put in this graft like this? Second, what happens if the graft gets rejected or if there is a problem? And what would be your backup solution in this situation, especially when you take off so much of trachea? What would you do?
You mean the traditional way if we for this trachea resection?
Yeah, if something happens, the infection settles, or the graft, causes necrosis. How would you proceed? They'll have a severe tracheoesophageal fistula, I would think, or mediastinitis.
Yeah, in this case, if something happened, we have to. Should be a pneumonectomy for this one, but for the tracheal replacements, it will be a tough case if we really failed and there's no any way for this patient.
There's probably no way out if the concept fails, but there are ways that patients are just ventilated into the distal trachea, and this is closed somehow. So there are concepts, but this is not a good quality of living. Any other question, comment? So thank you very much, and we wish you great success in this very challenging field. And I think we are ready now